Good morning and welcome to my YouTube channel, Painfree Partha. Now, there are two images. You can see this is one image and this is one image. Okay, one picture. Both are 70 years. Okay. Now, which patient will you like to anesthetize? This looks better than this. Okay. Why it is like this? What is striking in your mind? This patient, no, I'm slightly worried. This patient is okay. Not because white and black. Now you see, this patient is 83 years and this patient is only 63 years. Okay. Now because I need to show this identity because if you close the identity, it's very difficult to identify the sickness. That is why I have put this face also. This is 83 and 63, but she looks okay. So we are going to talk about frailty and anesthesia today. And greetings from our institute, Mahatma Gandhi Medical College and Research Institute, Pondicherry. It is a clinically recognizable state of increased vulnerability. What is that? They are increasingly vulnerable. Why they are increasingly vulnerable? Aging associated decline in reserve and function. That is the main reason, one of the reasons. And what is this vulnerability? The vulnerability is inability to cope up with everyday work. They are not able to cope up. For example, they walk daily to the toilet or restroom. They fall on and off. This inability to cope up with everyday or acute stressors. Acute stressor is an infection or infarction, trauma, what operation, etc. So what are five features? Five features: low grip strength, low energy, slowed waking speed, waking speed, low physical activity or unintentional weight loss. These are all the speed. They are not able to walk. That speed is less, physical activity is less, the strength is less. There is some weight loss. Now we can see very clear in these five, there is no decreased appetite. Very clear in this. I am very clear in this. Frailty, appetite, no. We need to have 3 out of 5 to say the patient is frail. There are scores 1, 2, 3, 4, 5, out of which 3 is frailty. There are a lot of index, 5P index, frailty index for elders. That is what I told. Do you need to help in getting out of bed? Do you need some help for bathing? Do you need some help for washing? Have you lost weight? Do you have a poor appetite? Yes, is there quickly full when you eat is very important. Did you have physical, emotional? Health is well. Did you get tired? Were you hospitalized? All these things are there, but you need just 1 or 3 to increase frailty risk. So I am again telling waking speed, tiredness, low energy, or grip strength is low, unintentional weight loss. These are very important when you say they are frail. It's a clinically frailty scale. You don't need to remember everything. Now you can see this picture. He is very fit. He is very fit. He is managing well. You can see here it starts slightly. This fellow has got something. Now this fellow has got double. Even though this fellow has got double, he needs some assistance. He needs some assistance. He is in wheelchair. He is in bed. He is completely terminally ill. Now you can see there is a transition from good to frail in 5 and 6. If you remember these two pictures, yes, they are frail. It is very difficult to score. He may not be frail, but he may be an old CVA. He may not be having a good grip strength. He may be some Parkinson's. He may be some heart failure. So it is very difficult to define in these patients how much frail they are. Very simple. My opinion is There are similar aged individuals. Are they weaker? Are they frail? Are they looking weaker? This is what is the important thing. It is not that they are very frail because they are 85 years. Look at the similar people. Now you can see this is an 85-year-old Tamil teacher. He is walking energetic. He comes to my house in the bike, or sometimes he gets somebody and sits in the bikes. There is no weight loss. He is there. He is gripping his book and reading stuff. So he is not frail. Now you can see there is an undernutrition because and goes into weight loss. This causes sarcopenia, means muscle loss. This causes decreased resting metabolic rate. He is not moving, muscle is lost. So again, there is a decreased intake because he doesn't need. Again, it goes to weight loss. This is a big cycle here. But this sarcopenia will also cause decreased strength, falls, and dependency. This is what I told 5 and 6 core. Dependency, falls, and injuries. There is an impaired balance because of decreased strength. Again, decreased. So he doesn't walk at all. So decreased total expenditure. He takes less. Again, it's a weight loss. Something like that. You need to break the cycle somewhere. Among people over 65 in the US, the incidence of frailty ranges from 7 to 12%, and it's around 4%, 5% in 65 goes to 85, and we don't have proper Indian data. So, what all prevents? Regular exercise, whatever exercise, in 75 years, whatever exercise possible, balanced diet, socio-economic status, very social and economic. Two are things, but somebody is not cared for in the society, then it becomes frail slowly. It doesn't take proper. Economic status, it doesn't have good paisa to have a balanced diet of daily fruits, nuts, crabs, etc. So it's a multi-pronged prevention. What they say, it's a chronic inflammation. Chronic inflammation is there. Then there are changes in the muscles, endocrine, hematological, and heart. This is what it reveals. That's what I told. No slowed performance, low activity, waking speed, weight loss, weaknesses, grip strength. All these things, signs will go outlets like disability. He cannot work. He has to depend on somebody. Any operative anesthesia risk and frequent falls from there again operation. So the risk factors are number one is aging and genetics, lifestyle, food, exercise. Other diseases can also influence this. For example, a patient with Alzheimer's disease, old CVA, can go into these things. Slowly, exhaustion, weight loss, falls. What they say is, if sarcopenia, age-related changes, decrease in sex hormones, higher levels of cortisol, and vitamin D deficiency. Now, there are a lot of scores. I have already told. 1, 2, 3, 4, 5, out of which 3. There is 1, 2, 3, 4, 5, 6, 7, 8, 9, out of which 5 and 9. A lot of scores are there. 5 face scores. Suddenly instinctive and striking in your brain, eyeballing. That is what this fellow is frail. I think I will get some problems in anesthesia. That is what is important. There is something called Edmonton app to find out whether we are frail or not. Now, very important about if there is a cognitive frailty, then we need to have a proper consult. Now, there is intermingling sarcopenia, cachexia, frailty. So, reduced comorbid illness, this is what we know. But what is important is cachexia is anorexia, and there is some underlying illness different. Cachexia will have malignancy. So, mostly, malignant cachexia they call. And anorexia is very important, but frailty, anorexia is not important. So there is an underlying illness in cachexia. If the patient has got a well-controlled heart failure but frailty, what is important is they may not have good recovery. They may have unplanned ICU admissions. Outcomes may be poor. This is what we need to bother about in these patients. So you can see here, Postoperative complications, postoperative delirium is more with these patients. Pre-anesthesia checkup, comorbid illness, drugs to discontinue, what is the physical status, and nutrition and diet. What we are completely neglecting is about rehabilitation. This is what one thing I want to stabilize, put in all our minds. Do a rehabilitation. There is no urgency. Some surgeries, prostate surgeries, wait for 3 weeks. Get him rehabilitated. What is this? Good nutrition, some movement. If the patient even TKR, do this and do this like this. Even TKR. Get out the social problems. Talk to the sons, daughters. Make him up well in front of social and economic status, if possible, and ask him to move with a balanced diet for 3 to 6 weeks. This is what is called rehabilitation in frail patients. This is supposed to better everything. Even if you cannot walk, you can do this gripping. Rehabilitation or some part of reversal of frailty. Maybe a fitter candidate for surgery. Nutritional, exercise training, psychological, social, all these things are needed. Sometimes you may need to address the financial problems also. Oh, yes, they have removed this. They may need to have rehabilitation for this immediately. Post-operatively, we need to. Sometimes we can put the hearing aid and start the surgery also. Those with level of frailty and perioperative risk, the option for non-operative management for a surgical condition should be given its consent. Yes, you are frail. Are you okay with non-operative methods? That is very important because sometimes you have a fracture and they'll become social extinct unless you operate and make them move. That is also important. So explain the pros and cons, cognition and consent. In anesthesia and surgical stress, number of pneumonia, collapse, very important. Frail patients, GA, pneumonia, collapse. There may be a myocardial injury, an acute kidney injury, post-operative delirium is very important. Delirium, these patients. And they slowly go, if you sedate slowly, they will go into sedation and go, don't take food and slightly sink. So this is very important. An acute kidney injury is very important. Frail patients, lung, kidney, myocardial injury, post-operative delirium. All these things are very important in post-operative complications. Yes, regional anesthesia has excluded most of the things because most of the patients are hip and knee surgeries. We can go ahead with regional anesthesia. We can go ahead with brachial plexus block, lower limb blocks. Yes, they have the cutting edge in frailty. Even there are a lot of patients, knee surgeries, hip surgeries done under complete regional anesthesia without not much of sedation. They develop post-operative delirium. That is another thing about frailty. Doesn't mean we need to give GA. A decrease in muscle mass, an increase in adipose tissue, reduction in total body water. This is somewhat intermingling with aging, so I'm not going into the details of that. Yes, that's it. Muscle mass has decreased, lipid mass has decreased. Very important is if the muscle mass is also decreased, your creatinine may not be the correct creatinine. So a 1.5 also in 85 years, beware. Yes, GA can cause liver blood flow, metabolism alter. Cardiac autonomic dysfunction. So that causes one. Number two, autonomic dysfunction can cause hypotension, problem with hypothermia in old patients, frail patients. So these cardiac autonomic dysfunction, BP fall, temperature. This is the autonomic problems in patients with frailty. Always we know lungs, increased chance of pneumonia, increased chance of atelectasis and hypoxia. So if you give just 50 mg of fentanyl, your airway reflexes may be blunted and he may have sedation and cognition defects. What do you think is the problem with GA? What do you think? Polypharmacy. That is avoided if you give a regional anesthesia with a nerve block. Yes, this is what is important. The patient has got a knee operation done, put in some adductor canal catheter and start infusion. Yes, the patient can move slightly and the patient can have food and the patient is mentally up. There is no polypharmacy and yes, all these things are better with this. Physicians fear of bleeding in frailty that we need to have movement, mobility, mobilization. That is what is important to decrease your so-called usages of heparin. Hearing aids, dentures, spectacles are with the patients. Early resumption of oral nutrition. That is what I advise. Most of the patient keep surgery 3 hours, immediately take food or your diabetic drug, all these things. Remove the catheters if that is not needed. Early mobilization, rehabilitation. Yes, we need somewhat, you need also a physiotherapist who should understand, a nutrition expert we should understand, or nursing with psychiatric nursing, because they may have problems with social status. A son or daughter may not come like. One's approach is called the proactive care of older people, POPS model, multidisciplinary, rather than reactive approach. You have delirium and then start approaching. That is reactive approach. You don't get delirium by using a POPS model. That is proactive. National survey only because many people don't, even in Italy, a survey has told frailty, people don't bother, and only half of them practice. There is strong evidence frailty increased the risk of morbidity spine surgeries. Frailty impacts patient outcomes, quality of life after surgeries. Now you can see these are frail patients, old age and frail. So what is needed in these patients? These patients for hip surgeries. Do one pen block or pen catheter with spinal or low dose regional epidural spinal. Then make them walk, make them mobilize, give a low concentration of drugs inside the pen catheters. Make them mobilize, make them sit, make them take oral fluid, slowly make them walk, remove catheters. This is what is needed. Rehabilitation and good nutritious food. So frailty is what is it? Yes, eyeballing, very important. We think that is something is strange. It is a 3.9 to 4%, which increases 25%. Why we need to worry? Complications are more. Atelectasis, pneumonia, cardiac injuries, kidney injuries, all are common. So polymorphisy is there with GA. We need to have prehabilitation in elective cases. Make them less frail. Make them move like this if we have a prostate and catheter already inside. And have a good balanced diet. Target is social and economic problems. GA and polypharmacy and postoperative period, cognitive dysfunction is very important. What is needed is POPS approach, proactive for older persons, not reactive approach.